Assalamu alaikum wa rahmatullahi wa barakatuh. So let's complete this topic of Goitre and Thyroid Nodule. So it's a very small topic which remained, which we have left. So we'll finish it off. Let's begin with the name of Almighty. Now, differential diagnosis. So what can be the causes? What are the different causes for this goiter or nodule? Okay. So systematic evaluation of thyroid structural abnormalities. So in that you should remember two things. One is you should know the anatomical nature of the gland. Secondly, you should know the functional endocrine status of the gland. Anatomical nature, by anatomical nature I mean you should distinguish between diffuse or nodular goiter, painful versus painless goiter. Why this matters? Diffuse goiter is usually seen in Graves, okay. Nodular is usually seen in multinodular goitre or toxic nodule, or nodular goitre, okay. And painful is usually seen subacute Duquervens thyroiditis, okay. That means viral thyroiditis. And also in painless and postpartum. So painless is seen in painless or silent, you can say silent and postpartum thyroiditis. And if there is no goiter, so that then the cause could be factitious thyrotoxicosis. So that's why this anatomical classification is necessary. Now functional, by functional endocrine status I mean, so it can be toxic, meaning that gland may be secreting more T3 and T4, or it can be secreting less T3 or T4, or the patient can be euthyroid. So start by thyroid structural abnormality. So first you should know the functional status. You can divide it into thyrotoxic, okay, and non-thyrotoxic, meaning either euthyroid or hyperthyroid. If the functional status, meaning TSH, free T4 and T3, if these functional tests show that there is thyrotoxic state, then the differentials are Graves' disease, toxic multinodular goiter, solitary adenoma, okay, painless destructive thyrotoxicosis, that is nothing but silent or postpartum thyroiditis, and painful destructive thyrotoxicosis, that is nothing but viral or granulomatous thyroiditis. And if there is no goiter, that is factitious. So this is not in our chart. No goiter. Why you will evaluate for goiter? So these are the causes of thyrotoxic goiter, thyrotoxic enlargement of the thyroid gland. Okay. Now how you will move on, differentiate between all these? That is the challenge here. Okay. So now you have differentiated that these are the different causes. So best thing is check the radioiodine uptake in these states. If there is a high radioiodine uptake, that means what that means, if the high radioiodine uptake means the gland is hyperfunctioning and excessive production machinery is working good, very much high. So that occurs in only these two tests, diffuse toxic or nodular toxic. Now if the you see the gland anatomy. If the gland anatomy is diffuse enlargement, then it is probably Graves' disease, okay. And you will have proptosis in that, pretibial dermopathy, okay. So these are all peripheral specific signs for Graves' disease, okay. And a palpable thrill and audible vascular bruit can be there if you auscultate, which is highly specific. Audible vascular bruit in the thyroid, enlarged thyroid gland, is very specific sign for Graves' disease. Confirmation is by TRAB antibodies, thyroid receptor antibodies. If these are positive, Graves' disease is confirmed. Now, if the gland anatomy is like it is nodular gland, then it can be toxic multinodular or it can be single nodular, solitary adenoma. So includes features revealing this will be asymmetric, nodular, lacking a vascular bruit. There will be no bruit in this, and there will be no autoimmune ocular signs, ocular or skin signs, they will not be there. And radioactive iodine uptake will be like it will be focal uptake. It will not be diffuse uptake. It will be focal uptake in the gland. That's how you differentiate. So it will be toxic MNG if it is multinodule, or it is single nodule toxic solitary adenoma. So this is known as hyperthyroidism now. So hyperthyroidism is a subset of thyrotoxicosis. Hyperthyroidism itself is not a condition. Thyroidism is a cause of thyrotoxicosis. By hyperthyroidism, we mean that the cause of thyrotoxicosis is overproduction of T3 T4. Okay, so this is hyperthyroidism. So when there is excessive uptake of RAIA, then there is hyperthyroidism. When there is low or negligible uptake, then hyperthyroidism is ruled out. When there is low or negligible uptake, then hyperthyroidism is ruled out. What that means? That means the cause for thyrotoxicosis is not hyperthyroidism, not overproduction of T3 T4. So those are ruled out now. Okay. Now the causes can be either leakage due to destruction, and that destruction can be due to viral infection or due to autoimmune condition. So destructive. So differentiate. Now if the radioactive iodine uptake is low or negligible, then differentiate the cause, whether this is destruction or whether this is exogenous ingestion. Exogenous ingestion usually does not have any Goitre itself. Okay, no Goitre. So we are dealing with enlargement, so we should go here. So destructive thyrotoxicosis, there will be evidence of follicular destruction. Now I said it can be autoimmune or it can be viral. See, this subacute thyrotoxicosis is actually a viral infection is a cause, and here painless is or postpartum is autoimmune actually. Okay, here if you palpate the thyroid gland, then pain will be present and inflammatory markers will be raised, like ESR will be raised in this patient. ESR, CRP will be raised in these patients. Okay, and this follows viral upper respiratory infection. Severe neck pain, classically the pain radiates to jaw and ears. There will be markedly elevated ESR. But in this, if this is painless thyroiditis and there is low radio RAIU, then that means it is autoimmune destruction of gland leading to leakage. So it is seen in two conditions, silent or postpartum thyroiditis. So this is driven by autoimmune lymphocytic destruction of the follicles, spilling preformed hormone. Crucial feature is unique negligible radioactive iodine uptake. So lymphocytic destruction is there here. Okay, that's how you differentiate. So this is how you differentiate. So thyrotoxic cause of enlargement of Goitre. Non-thyrotoxic cause, meaning the patient may be hypothyroid or euthyroid. Okay. So remember the causes of hypothyroidism. Mainly the causes were Hashimoto's thyroiditis or drug-induced thyroiditis or iodine deficiency. So that's only the cause of this. So if the patient has hypothyroidism or euthyroid, then that means, now what are the differentials? Check the gland anatomy. Look for diffuse gland only. Prompt for diffuse only differential. Okay, if the gland is diffusely enlarged, and one more thing can happen. The gland can be nodular, they can be MNG also, meaning there can be multinodular enlargement also, but that will be euthyroid or hypothyroid. That is known as non-toxic MNG. Okay, there the gland will be nodular, the gland will be having nodular enlargement, but focus on diffuse gland enlargement. So if then that is known as diffuse non-toxic Goitre. If it is diffuse toxic Goitre, then the differential will go to the Graves' disease. So simple differentials. Number one is simple colloidal Goitre. Number two is iodine deficiency. Number three is early phase of Hashimoto's thyroiditis. So patients who are having early phase of Hashimoto's thyroiditis, they will initially have this diffuse gland enlargement. Okay, and the patient may have normal T3 and T4 also. Okay, so three diagnoses. One is colloid simple Goitre, and this is iodine deficiency, and the third one is the Hashimoto's thyroid disease. So these are the three conditions. Okay. That's about the differential diagnosis. So differential diagnosis, first you rule out whether it is thyrotoxic or euthyroid or hypothyroid, then radioactive iodine uptake, then you move on forwards like this. Same thing. Okay, same thing. There we focused more upon not same thing, that was differential diagnosis. So what can be the diagnosis? Now we are focusing upon thyroid nodule or Goitre. So to rule out any cancer in that. So in differential diagnosis, we ruled out what are the different causes. Now we know the causes, and now we are ruling out whether this enlargement is possessing a risk of malignancy or not. So for that, this is the algorithm. So diagnostic algorithm for thyroid nodule or Goitre. Separate biochemical and sonographic assessment. Step one is biochemical functional assessment. Measure serum TSH. So initial screening test. If TSH is suppressed, it is thyrotoxicosis. If TSH is elevated, it is hypothyroidism. If TSH is normal, this is euthyroid. Now, if free T4 and total or free T3 is increased, then it is thyrotoxicosis. Okay, thyrotoxicosis. Okay. Now what you do? You do a radioactive iodine uptake. So if it is diffuse uptake, then the cause is hyperthyroidism. Either it can be Graves' disease or toxic adenoma or toxic MNG. If that is negligible uptake, then it can be destructive. The cause is destructive thyroiditis. Either it can be painless or postpartum thyroiditis or viral thyroiditis or excess recent massive iodine overload also. Okay. Now, if TSH is elevated, hypothyroidism, so you are checking FT4. Now, if normal FT4, then it is subclinical hypothyroidism, or if it is low FT4, then it is overt hypothyroidism. Check for anti-TP antibodies, then the cause is autoimmune Hashimoto's thyroiditis. Now, if TSH is normal, the gland is enlarged and TSH is normal, non-functioning lesion, then our primary clinical concern immediately shifts to ruling out underlying malignancy. Okay, this is not good thing, having a euthyroid state. So non-functioning lesion, our primary clinical concern immediately shifts to ruling out underlying malignancy. So one thing you remember, step 2 is structural assessment via high resolution ultrasonography, whether the patient has TSH normal or whether the TSH is elevated. So two conditions: if the TSH is elevated or the TSH is normal. So TSH is elevated, that means it is hypothyroid state. TSH is normal, that means it can be normal euthyroid state. Okay, or the TSH can be depressed also, then it is hyperthyroid state. So in any condition, whether the patient is hyperthyroid, euthyroid, or just you go on. The second step is do the high resolution ultrasonography of the anterior neck. This is an indispensable, non-negotiable next step. So here you do here the or radiologist will do 3D sizing of nodule, and according to that he will grade the nodule according to the ACR TIRADS criteria evaluation, which has 5 composition, that is 5 points like composition, echogenicity, shape, margin. Depending on this, he will give a grading like TI1 or TI2, 3, 4, 5. This grading will be given. Okay, and along with that, there should be survey of the central and lateral cervical lymph nodes. Why? If these lymph nodes are involved, malignant macrocalcified lymphadenopathy profoundly alters staging and surgical approach. So if the lymph nodes are involved, there is lymphadenopathy, will calcification, then that alters staging and surgical approach. That's why along with checking of the thyroid gland, one should check the surrounding lymph nodes, which is usually done. Okay, then see, in TIRADS, TI or TR, in TR1 and TR2, nothing is required, no follow-up, nothing. But in TR3, TR4, TR5, so in TR3, if the gland is more than 2.5 cm, then FNAC required. In TR4, if the gland is 1.5 cm, FNAC required. If the gland is in TR5, if the gland is more than 1 cm, then FNAC is required. Okay. Now it is less than 2.5 cm, then follow-up scan. In 4, if it is less than 1.5, then follow-up scan. In 5, if it is less than 1 cm, then follow-up scan. So that is how. Now we think like the patient is in this category, whether the patient may be having TR3 with more than 2.5 cm, or TR4 with more than 1.5 cm size, or TR5 with more than 1 cm size. Then that should be followed by FNAC. Now that should be followed by FNAC according to TIRADS scoring. So cytological evaluation, FNAC biopsy. So this is driven by cumulative TIRADS score and specific size thresholds. Ultrasound guided FNAC. Now you have, so using the Bethesda system, TBS RTC. Okay, Bethesda system. So according to TBS RTC 2023, okay, so it has 6, 1, 2, 3, 4, 5, 6. 1 is indeterminate, 2 is benign, 3 is AUS. AUS is ATP of unknown significance. 4th is follicular thyroid. 5 is suspicious malignancy. 6 is malignancy. So 6 grades are there according to the cytology. Now, okay, as we remember, 2 is benign. If it is benign, then it requires only serial sonographic surveillance. Maybe 1, 2 yearly. Okay, and give reassurance to the patient. That's all. If it is 2. Now, if it is 5 and 6, which comes under malignant category, 5 and 6, then surgical resection is required, rapid triage. Okay, so you should concentrate more upon these type of patients who have stage 5 or stage 6 of Bethesda system of cytopathology. Now, if it is indeterminate by I mean 1, 3 and 4, 1, 3 and 4. Now this will lead to a clinical dilemma. Cytology alone cannot rule out malignancy or differentiate a benign follicular adenoma from a follicular carcinoma. So that's why it requires histological proof of capsular or vascular evasion. It requires histological proof of capsular or vascular evasion. Cytology alone cannot rule out malignancy in this indeterminate causes. Indeterminate which and all comes in indeterminate 1, okay, 3 and 4. These are indeterminate. So to say this as malignancy, only FNAC is not required. So you need to do surgery, and after doing the surgery, meaning lobectomy, and if you see there any capsular or vascular evasion of after surgery, then you can say it as carcinoma. If there is no vascular capsulation, then it is not carcinoma. So that requires lobectomy actually. Or the second thing which you can do in this indeterminate categories is, that is one thing. So you do lobectomy and you rule out this capsular and vascular evasion. The second thing you can do is reflex molecular diagnostic testing. What you will do, you will test for these genes, BRAS, RAS, RET or PTC, TERT. So these genes you will test. So if these genes are positive, then it is carcinoma. If this is negative, then it is not carcinoma. Okay, that is the second thing you do. Okay, in this indeterminate categories. Okay, so these two will help us refine personalized risk of malignancy and guides complex decision. So either you can do conservative observation for these categories, or you can do a diagnostic lobectomy. So what you will do in lobectomy, you will see any capsular vascular evasion. If it is there, then it is carcinoma. Or you can do immediate total thyroidectomy also. Okay, that is the cytological evaluation. So for 5 and 6, immediate surgical resection, near total thyroidectomy or tight thyroidectomy. B9, leave. Indeterminate, decide whether lobectomy or molecular testing or near total thyroidectomy. So these are the 3 approaches you do in indeterminate categories of Bethesda system of FNAC. Management strategy. Okay, so this is important. Management of non-toxic goitre and benign nodules. So endemic goitre, where there is iodine deficiency, the cause is iodine deficiency. Okay, public health interventions are required. Prophylactic public health measures are important for endemic goitre. That can be achieved by 2 methods, number 1 and number 2. Number 1 is systemic iodine supplementation by iodized salt. Number 2 is impoverished or like in impoverished or isolated regions, you can do 2 things. So this iodized salt, so daily people will take and they will get iodine. So in impoverished or isolated regions, you can do 2 things. One is oral iodized oil. So this will work for at least 1 to 2 years, this oral iodized oil. Or you can give intramuscular iodized oil, and this will work for approximately 6 to 7 years. Okay, this will remain in the body this will work in the body for 6 to 7 years. This will work for 6 to 7 years, intramuscular iodized, and this will work for 1 to 2 years. So that is in iodine deficiency endemic goitre. Now what in patients who have, they are non-toxic but they are having symptomatic or compressive symptoms. So patient with MNG, SS symptoms, okay, like tracheal deviation, dysphagia, positive pemberton signs, then the definitive treatment is surgical excision is the treatment of choice, either total thyroidectomy or near total thyroidectomy. And if it is toxic, for example, if it is toxic, then you should first treat with anti-thyroid drugs. Okay, bring the toxic state to the euthyroid state, patient to the euthyroid state. After bringing the patient to the euthyroid state, then you plan for pregnancy. Okay, so because you are dealing non-toxic, we should go like this. Okay, so that's the point. Now minimally invasive interventions, benign nodules. No, benign nodules. What is benign nodules? Nodule will be there, but it is non-toxic. Non-toxic mean patient will be euthyroid. Okay, so what are the guidelines for benign nodules causing cosmetic or mild compressive symptoms where patient wishes to avoid surgery? Okay, mild, so benign isolated nodules not causing any symptoms, euthyroid patient. So and mild cosmetic reasons patient is having, So no need for going to surgery. You can do surgery, but the treatment of choice is this one: percutaneous ethanol injection. Percutaneous ethanol injection for cystic lesions. Or you can do the second choice is ultrasound guided thermal ablation. So you are destroying the lesion, the nodule, by giving injection of ethanol, or by heating the nodule by thermal ablation. Okay, these are the two methods. Now again the point comes, if it is toxic, then you can't go this through, you can't proceed by these two things. What are these things? Percutaneous ethanol injection or ultrasound guided thermal ablation. If it is toxic nodule, okay, if it is toxic nodule, and if it is benign category, toxic benign nodule, then first you should bring it to euthyroid state by giving ATD, and then you need to do surgery. Okay, that's the point. Okay, now initially the practice was give levothyroxine suppressive therapy for this non-toxic goiter and benign nodules, meaning non-toxic nodules, so that they may suppress in size by giving levothyroxine therapy, even though the patient is euthyroid. Now it is obsolete and it is contraindicated now. Why this practice is obsolete now? Because it has low efficacy, not effective for established fibrotic nodular goiters, and it has an unacceptable risk, induces iatrogenic subclinical thyrotoxicosis. Key adverse effects are on bone and heart. Bone, there will be accelerated bone mineral density loss, so increased risk for fractures, significantly increased risk of atrial fibrillation, potentially fatal, particularly in postmenopausal women and the elderly. So guidelines include Indian Thyroid Society consensus explicitly advise against routine TSH suppression for benign structural diseases. Okay, so that is about the management of non-toxic goiter and benign nodules, and also I discussed how to manage toxic goiter and toxic nodules which are benign. By benign I mean by thyroid scorings, they are come in the category of 1 or 2, or if they come in the category of 3 or 4 or 5, and you go for FNAC, in FNAC you get it as benign category 2. So those benign nodules you need to go like that. If they are toxic, you bring to a thyroid and you decide surgery. If they are non-toxic, so for a simple iodine deficiency, you give iodine either by iodized salt in isolated states, isolated regions. You iodized oil you can give orally, or intravascular injection of iodized oil you can give. And for single benign nodule, you can give either percutaneous ethanol injection, or you can give ultrasound guided thermal ablation. Okay. Now management of thyroid malignancy, ATA 2025 guidelines. Management of thyroid malignancy, differentiated thyroid cancer. So individualized, it is individualized risk adapted management according to the data framework. So data are four things actually: demography, age, response to treatment, and one more is something. So diagnosis and risk and benefit assessment. After diagnosis, you assess the risk and benefit for this thyroid cancer. Then according to that you will classify it as small gland with low risk of microcarcinoma. Small meaning less than 1 centimeter in size, and low risk of microcarcinoma meaning the stage is this one, CT1A N0 M0. So the criteria is there is no aggressive sonographic features, no subcapsular proximity, no lymph node metastasis. So what you should do in this case? Small low risk microcarcinoma. In this case, what you should do? You do active surveillance, safe, appropriate, and definitive management. So active surveillance, the criteria is rigorous ultrasound surveillance, avoid surgery morbidity. Second thing what you can do is percutaneous thermal ablation for this small size low risk microcarcinoma. Small size low risk microcarcinoma is either active surveillance or percutaneous thermal ablation. Recognized alternative, so this is favored actually, and this is alternative, avoiding surgical morbidity. Okay, now it is not small, it is unifocal intrathyroidal, okay, carcinoma, differentiated thyroid cancer. Unifocal intrathyroidal differentiated thyroid cancer, meaning the size is more than 1 centimeter now, 1 to 4 centimeter. So criteria: no gross extrathyroidal extension, so the stage is this one, no clinical nodal metastasis or distant metastasis. Now if this criteria is met, there is no gross extrathyroidal extension, there is no clinical nodal metastasis or distant metastasis, then simple thyroid lobectomy will suffice. No gross extrathyroidal extension, no clinical nodal metastasis, no distant metastasis, then simple thyroid lobectomy will suffice. So it is sufficient and oncologically equivalent. Oncologically equivalent, remember, minimizes the catastrophic risks. So during surgery, the main things which are to worry are there can be bilateral recurrent laryngeal injury and palsy. There can be permanent hypoparathyroidism because of removal of parathyroid gland along with this thyroid gland. Okay, these are the risks there. Now, if these conditions are not met, meaning the local, there is extra thyroidal extension, there is gross extra thyroidal extension, or there is nodal involvement, or there is distant metastasis, then patients who are having more than centimeter or gross extra thyroidal extension or clinical node or distant metastasis there, then total thyroidectomy is the treatment of choice. It is reserved for specific high risk cases. Same thing, more than 4 centimeters size, gross extrathyroid extension, clinical nodal metastasis, distant metastasis. Okay. Now, post surgical adjuvant radioactive iodine therapy should be given. When it should be given? So there is a post surgical adjuvant radioactive iodine therapy. So 4-tier classification. First you divide into 4 classification. You classify it as low risk, low intermediate, intermediate high, and high risk more than 30% and distant metastasis. So in low risk, less than 10%, routine radioactive iodine therapy is not indicated. In low to intermediate risk, it is conditional. Okay, intermediate to high risk, again it is conditional. Low to intermediate to high, it is conditional. High risk and distant metastasis, then it is strongly recommended. Target is residual microscopic disease and distant metastatic foci. So by radioactive therapy, as we have learnt, patient will have permanent hypothyroidism. Okay, so it will damage the cancer cells permanently. So it is not recommended in low risk and it is highly recommended in high risk, but in intermediate risk it depends upon case by case basis. You need to consider, it is conditional, depends upon individual basis. So that's about the treatment. So simple thyroid lobectomy or total thyroidectomy in large size carcinoma, okay, and small size, it is active surveillance or percutaneous thermal ablation. This already we have learned. I am not going deep into this. Management of hyperthyroidism. So for Graves disease and toxic nodular disease. So these are the 3 choices: anti-thyroid drugs, iodine therapy, radioactive iodine ablation, and surgical thyroidectomy. These are the 3 choices. Okay. In ATD, there are 2 drugs, methimazole and PTU. So first one is ATD. Okay, used in Graves disease and titrated over 12 to 18 months for immunological remission. So after 18 months, so we'll stop the ATD. So 50% of the patients will go in remission and 50% will relapse. So to those relapse patients will have these 2 options now: radioactive iodine therapy or thyroidectomy. Okay, PTU is second line and it has a severe risk of idiosyncratic hepatocellular necrosis. That's why it is used in specific scenarios only. So in first trimester of pregnancy it is used in thyroid storm. Okay, thyroid storm it is used. Okay, management of hypothyroidism is basically by replacement of T4. Okay, this already in detail we have explained in the topic of hypothyroidism. So this also we have learned, but just we will see the contraindications and adverse effects and standard dosages. Okay, so because in the previous videos some differences are there in dosages, but when I search there is no difference. It depends upon the dosage, depends upon the severity of the disease. Levothyroxine and hypothyroidism, the dose is this much. Okay, in elderly the dosage is 0.3 to 0.5. This is not mentioned in previous videos of hypothyroidism. So it is 0.3 to 0.5 microgram per kg per day starting, or you can start with 25 microgram. So the total dosage is this much: 0.3 to 0.5 microgram per kg per day and titrate slowly. So this is the total dose actually, I think, and this is the starting dose. And this is contraindicated untreated adrenal insufficiency. Adverse effect: subclinical thyrotoxicosis AF, osteoporosis. So the important things which I have discussed must be taken on an empty stomach. This calcium or iron supplements along with stomach drugs, 4 hours gap should be there, and some drugs increase the excretion like anticonvulsants. So there the dosage should be increased, and immediate upon confirmation you should increase 30% dose increase upon confirmation of pregnancy. So methimazole Graves toxic mg dosage is 2.5 to 10 is the maintenance dose, and up to 40 mg you can use the dose depending upon the severity. First line, contact in first line pregnancy. Main adverse effect of this is agranulocytosis. So because the main effect is agranulocytosis, again you should have a baseline CBC complete picture along with LFT, because agranulocytosis and hepatic side effect is there, that's why. And you should warn the patients to report fever, mouth ulcers or sore throat immediately to rule out agranulocytosis. Fever, mouth ulcer or sore throat immediately while the patient is on the drug. So to rule out any agranulocytosis. Pro PTU, so first emitter use, so the dosage is actually 100 to 150 TID. Okay, here it is 100 to 200. In thyroid storm, the dose is actually 200 to 400. Okay, TID. But here it is given 500 to 1000 loading dose, then 250 TID. Okay, depends. Okay, but the important side effect is hepatotoxicity here. So this is symptomatic control. All things we have discussed everything. Lugol iodine, thyroid storm you use this, and preoperative preparation, 5 drops. So 3 to 5 drops is the in preoperative preparation you use 3 drops TID, whereas in storm you use 5 drops TID. Okay. Pitfall, this is important. In thyroid storm, iodine must be administered more than 1 hour after initiation of PTU methimazole to prevent the gland from utilizing the iodine load for new hormone synthesis. Myxedema coma, thyroid storm, hydrocortisone should be used in myxedema coma and as well as in thyroid storm. So this is emergency situations. So here it is given in thyroid storm, you should use first a loading dose of 300 mg IV, then 100 mg TID. Similar to PTU, loading dose of 500 to 1000 mg, then 150 mg TID. It's given in here. So the main thing contraindication is systemic fungal infections, hyperglycemia, hypertension, immunosuppression. Critical pearl is in myxedema coma, empiric stress dose, steroids must precede T4 T3. Okay, otherwise it will precipitate adrenal crisis. Okay, that's all. We have finished this topic and all the cardinal manifestations of the thyroid gland. Thank you.